All right. Well, good morning, friends. Thank you so much for joining on Christmas Eve, right? Like, we are super excited that you are spending your holiday time with us so that we can learn together. And I'm so excited today. I'm discussing with Yusuf. Last time I discussed was a while ago when I remember it was a case of a Still's disease, which we discussed together. And then one before that we discussed was like cryptococcosis. So it was like always a blast with Yusuf because the thing with Yusuf is that, he gives me these prompts like, he will be probably researching on his computer what's going on, like what are the differences, and then he will ask these pertinent questions that, hey, what do you make of this ESR being completely normal? So it is very good with him that our chemistry works fine. So I'm excited for today's discussion. And Shreya is presenting a case to us. So maybe I can pass the mic to Shreya. How are things with you?
Yeah, sure. Hi, everyone. I'm Shriya Upadhyay. I'm a medical graduate from Nepal. I have been fortunate enough to work with this family for a while now. And yeah, I'm very, very excited for today's discussion and session. Yeah.
Perfect. And I think Sarah is helping with the scribing. Sarah, how are things going there?
Going well. Really glad to be here. My name is Sarah. I am a fourth year student at Emory applying into neurology and calling in from California today.
How is weather there, Sarah?
It is pouring outside. Um, I think there's supposed to be like a big storm over the next couple of days and like 4 inches today. So
It sounds rough.
I don't know. It's maybe fitting for the like winter, like Christmas spirit. And I think the mountain should get some snow too. So we'll be able to have a nice little view sometime in the next couple of days.
Yeah, sure. I also wished that we had a snow here, but in St. Louis, surprisingly, over next couple of days, the weather is like pretty good. Like it's warm, if anything. It's not cold at all. So I don't know what happened, but well, hopefully maybe a tiny bit of snow can come later, and that would be the Christmas spirit. Perfect. And then I think Ivan is helping with the teaching points today. Ivan, how are things going with you?
Hi everyone. Everything's going great with me. Third year med student. I'm wrapping up my Christmas kind of break here. Just excited to, learn today and get things going.
Awesome, perfect. Thank you so much for being here. And we can get started with the case, Shreya, whenever you are ready.
Sure. So we have a 19-year-old male presenting with a complaint of difficulty walking and left hip pain and inguinal region pain as well for 4 days. I'm gonna stop here.
Go for it, Yusuf.
Yeah, hi everyone. I'm Youssef. I'm a CP Solvers member. I think next month it will be 3 years of being part of this group. I'm currently a hospitalist at Emory. Excited to be here today. 19-year-old male with difficulty walking. Wow. I think immediately my brain is trying to localize the lesion, right? Like, whenever you hear you can't walk, you can go anywhere on the neural axis. It can be the nerve, the neuromuscular junction, the muscle, the bone, even the spinal cord or CNS. But I think what's really standing out here is we hear about left hip and inguinal pain. So I'm really, really wondering about that left hip joint. And whenever somebody is younger, you think about genetic disorders or exposures that might put this patient at risk. Uh, and I'm quickly trying to think if I'm going to see a patient now with hip pain, what are the things that I would do? And Robbie teaches this often is what physical maneuver would I do? I think the one big thing would be active and passive range of motion, because if you have pain both with active and with passive, then the pathology is likely in the joint. While if you have pain only with active but not with passive, then the pathology is likely not in the joint. Kirtan, what are you thinking?
Yes, Yusuf, I agree with you that in a young person, you are really, really interested that what can be going in the left lower quadrant and that region, which is why this is going on. And I'm going to borrow the concept which like Rabi teaches us very well, right? That this patient had some kind of pain, which is which we can equate as a discomfort. But now that has translated to difficulty walking, which is a dysfunction. So whenever discomfort moves to dysfunction, things are getting serious. You need to figure out what's going on. I can have pain for 5 years and it will be fibromyalgia, but I can have pain for 5 years and I can have ulcerations all over my tips, and then it was like vasculitis, right? So what I'm trying to say is that whenever you have dysfunction, it's terrible. When it is discomfort, you still have a time to breathe. In such a young person, within 4 days, he cannot walk. That's very disconcerting, right? So I'm trying to focus all my energy on figuring out that what it takes for a young person to walk and why he or she is not able to walk, right? So if you ask yourself that if you need to walk, what needs to happen, right? First is that you need to stand up, right? And when you stand up, you need to make sure that your orthostats, like your blood pressure, has to go up in the right amount so that you can kind of prop your energy systems up, right? Which is what is not happening in our case, right? Patient doesn't have a syncope, doesn't have dizziness, doesn't have blurry vision. So first part is that your orthostats are fine, your blood vessels are functioning okay, your autonomic nervous system is functioning fine. Then if you imagine, if you start walking, the first thing which you need is the proprioceptive input from the outside, right? So if there is some kind of impaired vibration proprioceptive deficits, maybe you can have some difficulty in walking. So this is the sensory arm or sensory component of how you can walk, right? Once you then think about going all the way, those signals will be relayed to your brain. Your cortex will interpret all the signals. It will integrate it with the cerebellum, basal ganglia, and then it will give the motor signals all the way to your left leg so that it can start walking, right? So that is the motor arm of it. And if you like microscopically zoom in, then that motor now has to go all the way to neuromuscular junction, all the way to the muscles, and that muscle will start contracting, and your osteoarticular apparatus will start functioning, right? Now, the reason why I laid down this axis is to give you a general overview of what it takes to start walking. But we can completely narrow it down to finally the osteoarticular structures in this case because of the fact that there is a significant pain and it happened acutely, right? All other things which I discussed so far are so deeply ingrained into the neurology world that you will have other signs and symptoms and patient won't present in this way, right? So now my focus is to find out what Yusuf said in the first part, right? That what can be wrong in the osteoarticular structure in that region. So in order to walk, your hip joints have to function fine, which means the femoral head, which is inside the acetabulum of your hip joint, that joint has to be intact functionally. And the surrounding periarticular structures, which means all the bursas which are surrounding that joint, has to function as well. Now, when you stand up, your hips have to flex and you have to bear weight. In order to bear weight, the most important muscle which helps is the iliopsoas muscle, which comes from the like iliac region and all the way inserts into the femoral head. And that is the muscle which helps you in like contracting your hip and bearing the weight, right? So if there is anything wrong with the iliopsoas muscle, its anatomy, then also you can have this difficulty in like standing or walking. And now the reason why the pain becomes important is you could imagine that in the inguinal region, what are the structures which are there, right? You have your sigmoid colon, you have the rectum, anything which is wrong in those region, let's say there is a diverticula there. Let's say there is an abscess there, right? You have an inguinal lymph node. Let's say there is inguinal lymphadenitis there, right? Let's say there is some kind of blood collection in that region. Maybe you have hematoma because of rupture of something. Now, all this kind of complication in that localized region can infect your iliopsoas muscle, can affect your hip joint, and that is why you are having pain and you are not able to walk as well, right? So that is what my mind is to try to figure out that what is the anatomy of that region and how that can impact the walking by adversely affecting the functionality of different structures there. What do you think, Yusuf?
Yeah, I think we just want to hear some more information, maybe some past medical history and examples. Shri, I can't wait to hear more.
Yeah, sure. What a great start. So yeah, 2 weeks before presentation, patient had intermittent fever for a week, which subsided when taking antibiotic medications. There was no diurnal variation, no rash, no purpura, or no other systemic symptoms. A week before, he started having difficulty bearing weight, and since 4 days, he has severe left hip and inguinal pain. No genital or oral lesions present, no urinary complaints. The patient has no past medical history. He rarely visits hospital. No medications or allergy history. He lives in hilly region of Nepal. He is a student. He smokes one pack of cigarettes. He does not drink alcohol, and he has never been sexually active. And I'm gonna stop here now, and I want to ask, like, what do you expect in the examination?
Perfect. Good start, Shreya. Like, very interesting, right? That we were thinking that, okay, maybe something is wrong in that quadrant and we need to figure out what it could be. And now we have some prodromal symptoms. And it is also interesting because of the age of the patient, right? That why would a young patient present with 2 weeks, like prior to 2 weeks, patient had some fevers which went away, and now patient cannot walk at all, right? And there is severe pain in that region. So if that fever, if we just imagine baseline rate of the diseases, maybe that was a viral infection, right? But we are not hearing any upper respiratory tract symptoms. Patient doesn't have sore throat, doesn't have fevers, doesn't have cough. Another common way in which you might end up getting some degree of fever is maybe there was viral gastroenteritis, but we are not hearing anything about diarrhea or constipation either. So when you rule out these two common pathologies, like common base rate diseases which can cause fever, things get more and more tricky. That is it possible that this person had some pyogenic foci of infection somewhere in the body, which we are not able to track down at that time? Did this person have abscess somewhere in the body? Let's say a liver abscess, let's say a lung abscess, let's say something in the colonic abscess, or let's say in the rectosigmoid region, because often abscesses are one of those things that we think they will present with fever and localized pain in that region. It may not always be the case, and maybe the fever will subside and then it will come back again, right? So it's one of those sneaky causes of fever that you can miss because it's just localized pyogenic foci of infection, right? So I'm trying to ask myself that if this young person got fever at that time, what was the reason for that? And how can we link it to the current presentation, right? And regarding what Shreya asked us, that how would we proceed with the examination? So first and foremost is the osteoarticular examination, right? That if you try to move this patient's hip joint with like passive and active range of motion, and if there is limitation in that, and if there is a severe pain, then you know that probably you are dealing with joint space. So maybe there is arthritis of some kind there. It could be any kind of inflammatory arthritis, infectious or non-infectious, or something is wrong with the joint itself. For example, maybe femoral head has like osteonecrosis, let's say, or there is osteonecrosis of the hip, right? So these are the two pathologies which you have to entertain when something is happening acutely, right? The third possibility is that maybe you are bleeding in that joint. So that is what we call as hemarthrosis. That if you have spontaneous hemarthrosis of that left hip joint, then you can have severe pain and limitation in the range of motion. So we want to see the range of motion. If range of motion is fine, like active and passive, but there is just so much pain when you are trying to move it, then the focus shifts from inside the joint to surrounding joint spaces. And that's when we talk about what is there in the left lower quadrant, right? Like, is there an abscess there? Is there a hernia there? Is there a bleeding there? Right? So that would be my approach. And maybe now I can ask Yusuf that how is he putting all of this together?
Excellent discussion, Kirtan. I think I agree. I think one thing I'm thinking of is this arthritis? Because you're alluding to it subtly, but is there like a septic arthritis? Is there like a reactive arthritis? So I think that's one thing I'm keeping an eye out for on the exam. And then the other question is this a complication of an infection? And we're translating fever to infection, which is because the most common cause of inflammation is infection. So we're thinking, is there an abscess? Is there a septic joint? Is there an osteomyelitis? But then we also have to think, is this non-infectious at all, right? Is this the start of an autoimmune disease? I think that's less likely, but I think you would want to keep an eye out for it. I think what I want to know on exam is, like Kirtan said, are we localizing to the joint or is this outside the joint? I think that will be the pivot point, because if we hear that, okay, we have pain both with passive and active, we're localizing to the joint, I think we don't go down that pathway of like infectious, crystalline, reactive, etc. And then joint tap would be the next step. But then let's say we don't see about localization to the joint, then we go down a different pathway, and maybe a different type of imaging would be warranted. So, Shreya, can't wait to hear more.
Awesome discussion. So yeah, patient is afebrile. Heart rate is 90. Blood pressure is 120 by 70. Respiratory rate is 15. Saturation is normal. General exam patient looks normal. Eye and oral examination is also normal. Heart sound is normal. Chest examination normal. Abdomen is soft, non-tender, no organomegaly. Neuro examination is normal as well. In MSK, Left hip held in externally rotated position with restricted internal rotation, abduction, and flexion of left hip. Also, pain in the insertion site of iliopsoas on the left lesser trochanter. Other all MSK examination is normal. I'm gonna take a brief pause and hear what you guys think of this.
Excellent. Kirtan, I think we're making very rapid progress. So I think I'm gonna pause for a 2-minute breakout room for people to discuss and think. The question is, what do you think the differential is? What is going on? What you would do next? So I'm just gonna open that for a brief 2 minutes. Welcome back, everyone. Is there anybody who would like to share their thoughts or what you all discussed in the group? And then feel free to put it in the chat as well. All right. So I think we hear like some groups want some imaging studies, some groups just socialize. It's all good. So I think Kirtan and I were chatting and we were discussing where are we localizing this lesion or where is the lesion in this case? And even though typically you hear that if a joint is externally rotated and fixed, you wonder about fracture. But given the patient's age, you wonder is the pain the limiting factor or the reason why the joint is very externally rotated, and especially with the pain at the insertion points of the muscles, you're wondering, is there like a inflammation in the joint and around it as well? And I think one thing we're thinking of is, do we need to better image this joint, and do we need a joint aspirate, and to figure out this lesion further? And we also wanted to think if was this pain limited range of motion due to pain, and that's what we were thinking. Kirtan, what would you add?
I agree with you, Yusuf. We need a more detailed examination and some basic labs which can guide us our next step.
Sure. So I'm gonna give some initial labs. Hemoglobin is 20, WBC 14,000 with neutrophil 80%, lymphocyte 12%, platelet is 3.5. Urinalysis is normal, renal function and liver function tests are normal, chest x-ray is normal, CRP is 13, ESR 53. X-ray of hip showed no sacroiliitis, no other lesions except some haziness around left lesser trochanter. RE factor is normal and ANA factor is normal, and I'm gonna stop here and hear what you guys think of this.
Yeah, thank you, Shreya. And just to clarify, is the hemoglobin and the platelet counts, are they low, normal, or high in your lab?
Hemoglobin and platelets are normal.
Okay.
All right, well, thank you, Shreya, for this piece of data. So it looks like we are dealing with a young person who is presenting with subacute inflammatory syndrome, as evident by the presence of fevers, elevated CRP, and leukocytosis. And in trying to figure out where is this inflammation stemming from, so far, based on preliminary imaging, we have been able to figure out that maybe something is wrong in the left hip region, something wrong with the osteoarticular structures. And we saw that there was some haziness at the level of insertion of the iliopsoas tendon, right? Now, what can that haziness represent, which is what we need to figure out. Now, first and foremost, as we know that when we are dealing with the bones and the soft tissue, the best imaging study is the MRI, right? So eventually we will need MRI or at least CT scan to figure out that what that haziness actually represents, right? But if we just try to create a differential of what it could be, first is it could be just inflammation, which is what Yusuf was saying initially, right? That maybe there is tenosynovitis of that region. Now, tenosynovitis usually happens in the hand joints more common than other joints of the body. But depending on what kind of pathology is causing it, you can end up having tenosynovitis anywhere else in the body. So that is one possibility, that maybe there is tenosynovitis of the iliopsoas joint, right? Another possibility is that maybe there is something wrong with the bone itself. Maybe there is a focal osteomyelitis in that region, or periostitis. Maybe that is why you are seeing the haziness. And then based on the imaging, we can figure out more that why would someone get focal bone inflammation in that region, right? The third possibility is that maybe we are dealing with the early onset of the pyogenic complication there. Maybe there is an abscess growing in that space, the soft tissue space, which is still in the early stage. Maybe that's why we are just seeing haziness, and eventually it will coalesce together and it will form a well-rounded abscess, right? And MRI will help us making that progress. So that is third possibility which I had. And finally, I'm asking myself that whatever we are seeing on imaging, is it going to be enough explanation for everything else which is going on? Like, would we be satisfied saying that, okay, this is it, or do we need more thorough workup, right? So eventually, I think what Yusuf was saying, right, that we still are not clear if the problem can in with the hip joint itself. So with the X-ray, you cannot diagnose septic arthritis, right? And in fact, you cannot diagnose septic arthritis even by like MRI or CT scan conclusively. You will need joint aspirate. So in this case, getting a joint aspirate would be the first priority, because you don't want to miss a hip joint infection, because that can be very fatal if you don't address it quickly, right? So I will proceed with that at least if possible, and then do a thorough imaging of that region to make progress as to where is this pathogenic foci of infection, right? What do you think, Yusuf?
Kirtan, excellent discussion. I think I like your differential, but it sounds like you're very thinking of like very much of an infection, because you mentioned like an abscess, septic arthritis, or osteomyelitis. Where does like autoimmune or reactive and malignant fall on your like differential list? And are you considering them at this juncture, or are you like, oh, I need to rule out infection because they're 19, and then after I rule out infection, then I can think of other etiologies?
So no, you are bringing a good point that it may not be infectious at all, but it's just like we are thinking about the diagnostic arc of evaluation, that maybe first rule out the infections, like something which is more dangerous. But then you are right that down the line we have to entertain that, can it be autoimmune condition which would present in this way? The only part which was a little bit dissuading me from that initially was the asymmetric presentation, but we know that diseases can present asymmetrically initially and then can transform to the symmetric fashion. So yeah, that we have to entertain that as well. And maybe Yusuf, you can kind of enlighten us as to like what autoimmune disorders might present in this way.
Absolutely. So I think, like you're saying, like infection is most common in this age group. And I think the other thing I'm thinking of is like, what is the susceptibility of this patient, or why are they developing this condition, right? So do we need to screen for HIV just to rule out a susceptibility that we're not seeing? Uh, just when evaluating this patient initially, do we need to look at the MCV, make sure they don't have any sickle cell trait or sickle cell, to make sure they're not at risk for encapsulated organisms? These are the things I'm like thinking of like off the top of my mind. And I know someone mentioned tuberculosis in the chat. I think just like the prevalence is makes them at risk for TB, but it's still very acute to subacute, which is making it less likely in my mind. And then in terms of autoimmune disorders, I think reactive arthritis, we don't think of it as autoimmune, but it is on that spectrum. You have a genetic susceptibility, then you get exposed to an antigen, and then you get an autoimmune form of seronegative arthritis. That's the biggest one. I'm not thinking of crystalline arthritis just yet, and I'm not thinking of like seropositive arthritis just yet. Even though there are like forms of RA that present in younger age groups. So I think like you, Kirtan, I want to know this patient's susceptibility, uh, maybe see if there's like any purulent infection, because that's the biggest thing you want to rule out. Is this, because if it is in the joint, you're thinking, is this staph or strep? Is this pseudomonas? Is this salmonella, right? These are like the biggest like categories that are quickly reversible with antibiotics, and possibly need source control as well. So I'm there with you, Kirtan. Infection, and then consider other etiologies as you rule out the initial differential. If anybody has any other thoughts, we'd love to hear them. Feel free to put them in the chat as well. Back to you, Shreya.
Awesome discussion. So I'm gonna give some more labs now. Uh, so we have ultrasound of left hip and thigh, which showed fluid collection in joint space with minimal thickening of capsules. thickening of iliopsoas bursa with thin walled fluid collection along the line of iliopsoas tendon, no connection between the iliopsoas and hip joint. Synovial fluid analysis showed translucent fluid with WBC of 23,000 with 58% neutrophils. Gram staining revealed no organism and fluid was negative for crystals as well. USG of right hip was normal. Blood culture was normal. Hepatitis negative. Hepatitis B and C negative. HIV came back negative. RE factor was normal and ANE factor was normal as well. We sent HLA-B27 and some infectious panels since we didn't have a certain organism in synovial fluid analysis. And the results were pending. So I'm going to take a brief pause and listen to your thoughts now.
Excellent presentation, Shreya, an excellent case. So the question is, we get this question very, very often on the boards, on exams, in real life. Is this septic arthritis or is it not septic arthritis? And I wish there was one test that you just send one test and then you immediately know the answer. But we don't have that just yet. Maybe in 10 years, 15 years, probably. We'll just send a carriers PCR on all joints and then you'll know on time point 0. But so the classic teaching is that if you have a white cell count more than 50,000, then you're pretty sure this is septic arthritis. In real life, the higher the white cell count, the more likely that it is septic arthritis. So if it's more than 100,000, you're pretty confident. If it's more than 50,000, you're also confident. If it's more than 20,000, it could still be septic arthritis. It's just the probability is just a little bit less. And the other question is, do you need to start empiric antibiotics or do you have the privilege of being able to wait? So the other thing you think of is the gram stain. So let's say at time point 0, you check the gram stain. If it's positive, you're like, okay, this is the probability is probably high. I can start empiric antibiotics and then see. The third thing you think of is crystals. So let's say we did see crystals here. Then does that mean that septic arthritis is necessarily less likely? Probably not. Because you could have like crystal arthritis and septic arthritis at the same time. And then the last thing you consider is, do you need to treat before diagnosing? So is this patient immune compromised? Do they have risk where they're not able to mount an immune response? Or do you need to just start them on empiric therapy until you find out what's going on? And do you have the privilege of that? Back to this patient. So we have a white count of 28,000, which is elevated, but not the slam dunk for septic arthritis. We also hear that gram stain is negative and other inflammatory symptoms are not clearly positive. So in this range of 20,000, I think a few things you think of. You consider sexually transmitted infections. So disseminated gonococcal infection, for example, can infiltrate joints and do not routinely come back as positive from sampling from the joint. So you would actually need to test from other sites where the patient is sexually active. So you might send a throat swab, you might send a urine testing, etc., depending on the patient's sexual activity. And then you also consider reactive arthritis, which, like we mentioned earlier, you get an initial exposure. You have a gene that predisposes you to develop inflammation a few weeks after initial exposure. And this can happen with enteric organisms. So it can happen with like E. coli, Campylobacter, Shigella, etc. And then you develop it weeks later. These are the big two contenders in my mind. Is this like a sexually transmitted infection versus is this a reactive arthritis? And I think we definitely need an HIV screen, an A1C, like we said. And then in terms of like empiric antimicrobial therapy, actually, I'm going to ask you that question, Kirtan. Like, what are your thoughts and what would you, management reasoning, what would you do next?
Right, Yusuf. So, firstly, all we saw on imaging was that there is some kind of inflammation along the tendons and in the joints. And our task is to figure out whether this is infectious inflammation or non-infectious inflammation, right? But given that the chances of missing infections can be like catastrophic if you don't intervene right away, that's why we want to start empiric antibiotics, right? Now, based on your susceptibility, the choice of empiric antibiotics varies. But in this person, since at baseline we don't have any clear evidence of immunodeficiency, either from humoral standpoint or cellular immunodeficiency standpoint, we can assume that the patient is immunocompetent. Then the question becomes that we will give empiric antibiotics based on the most common organisms which can cause septic arthritis, right? So Yusuf mentioned the four big S's, right? So staph and strep are considered as the most common cause of infectious arthritis, no matter what your susceptibility is, right? So in order to cover the staph and strep, you will need vanc and ceftriaxone. The reason why vanc, because you don't know if the staph can be MRSA positive or not, right? So vanc is definitely there. And then the ceftriaxone, because it can cover almost wide range of gram-negative organisms, which can end up affecting your joint. Now, if someone had a history of, let's say, drug-resistant organisms, like maybe they have Pseudomonas, maybe they have like diabetes or any other immunodeficiency which can predispose you to Pseudomonas infection, then you want to try those antibiotics which can cover Pseudomonas. So classic choice could be cefepime, or some people can even go more broader and can give piperacillin tazobactam like Zosyn if there is a concern that maybe there is some degree of anaerobic organisms involved as well. Maybe this person has been in the hospital multiple times before. Maybe that is what is increasing their risk, right? But in this person, again, a young guy never has been to the hospital before, then at least as of now, I would be satisfied with starting them on vanc and ceftriaxone. Now, it's very important to understand that Yusuf mentioned that there are some sexually transmitted infections which can present in this manner and which may not show up on the cultures and may not elicit the robust neutrophilic inflammation in the joint space. So one classic example is gonorrhea. And then other examples are like mycoplasma species. So you can have like mycoplasma genitalium, mycoplasma hominis, which can be in your urinary tract, and they can end up triggering reactive arthritis as well, or they can directly seed those joints. And oftentimes, the antibiotics which we give, like vanc and ceftriaxone, may not appropriately cover those organisms. Maybe you need, like, let's say, doxycycline or azithromycin, but it's not in the empiric treatment guidelines because just the base rate is low. So often you don't start them on those antibiotics until you have more data, right? So I would start this person on vanc and ceftriaxone. And regarding the diagnostic workup, I agree with the Yusuf, right? That we do want the STD screening. So we want like urine, oral cavity, rectal, all three sides. You need gonorrhea, chlamydia for sure. And at least from the urine, you should get mycoplasma genitalia, mycoplasma hominis PCR to get a better idea of what's going on, right? And HIV testing was, I think Shreya said it was negative, but whenever someone presents acutely, you don't want to take the risk. And even if HIV antigen antibody screen is negative, you should obtain the HIV RNA because that could like change the calculus altogether, right? So I would go ahead and get the HIV RNA. The second thing is that if it is not infectious, let's say, then what non-infectious buckets outside of reactive arthritis still remains? That I would say that it's a little bit hard to make the progress because we don't have any evidence of systemic symptoms anywhere else. No other joint is involved. No other organ seems to be involved as of now. So hard to make the progress. But one point I would mention is that since the inflammation is so much centered in that particular region, in order to make sure we are not missing any other kind of anomalous connection from the left lower quadrant to the joint is very important. So getting the MRI of the abdomen and pelvis, or at least the CT abdomen and pelvis will be important because as we said in the first part that like iliopsoas muscle plays a crucial role in standing up. And often there is iliopsoas, let's say abscess or any inflammation, then you might have difficulty in standing up. So you need to make sure there is no pyogenic foci, right? So I think getting the scans of that region will be important while we pursue the serological workup from different sites and the blood. And maybe I can pass mic back to Yusuf to think about any other like rare diseases which might present in this way.
Yeah, and Kirtan, just before I answer, for iliopsoas abscess, what do you think of the source of the iliopsoas abscess? Do you think of like UTI or intra-abdominal infection?
Yeah, no, good point. So like in general, the most common cause you would assume would be from the localized foci of inflammation. So let's say someone has diverticulitis in that region. Maybe let's say someone has proctocolitis from any possible cause, and that ended up causing the abscess formation in that region. And then systematically speaking, you might think that, okay, maybe they have a bacteremia going on, maybe they have endocarditis going on, and maybe that ended up seeding that region. But as we know that bacteremia and endocarditis, the patients will generally look more sick and you might end up having foci of infection anywhere else in the body, which we are not seeing. So that's why like I'm prioritizing the local causes more than the systemic causes, but systemic causes are not off the hook for sure.
Yeah, that's great. And I think I'm in the similar mindset as you, Kirtan. I think biogenic versus sexually transmitted infection is like the most common infections. I'm surprised it's very, very localized. So that's why I'm like trying to consider like, oh, is this like a component of like a infection versus reactive arthritis? And Shreya, does the next aliquot reveal the diagnosis?
Yeah, pretty much.
Okay, okay. So a lot of people have voted in the poll, so I'm gonna share the poll and share the results with you all. So a lot of very well distributed. A lot of thoughts about STIs, pyogenic infections, reactive arthritis, and then Kirtan, what is your top two good differentials? What do you think it's gonna be? I know it's hard to say, but I think just what are you thinking?
Yeah. I would say STI versus focal pyogenic complication, which ended up. And I don't have an answer for why focal pyogenic complication happened there yet.
I think it's really hard to say. I think my mind is like maybe with a 2 week time difference, I'm thinking of reactive arthritis, but the only way to know is to rule out pyogenic infection first. So, but I think that's where I'm at. So, Shreya, back to you.
Yeah, awesome discussion. Such a fun one. Uh, yeah, so we consulted orthopedics and radiology, and we came to know that the USG finding is source synovitis and bursitis, and the combination of both raises clinical suspicion for reactive arthritis. So we did send urethral swab for gonorrhea and chlamydia, which came back negative. Uh, so you and actually B27 came back. The results came back negative, and blood culture was negative. I don't remember if I mentioned it before. So keeping the epidemiology of diseases in these areas in mind, we started exploring all the infectious panel. So we sent a few tests. uh, I will tell you the name. So yeah, tuberculin skin test came back normal, negative. I will tell you five tests that we sent, and one of them is the diagnosis. And I'm gonna leave for you guys to think which one came back negative. So I'm gonna list out malaria antigen, dengue antigen antibody, brucella, leptospira, and scrub typhus. So yeah, which do you think came back positive?
Wow, yeah. So just to maybe recap for the people listening about all these infections, malaria is vector borne, typically undulating fevers. You can have cerebral malaria. Typically, it does not localize to just like one joint. Uh, Dengue is also vector borne. Usually, you have a vascular leak phenomena, high grade fevers. A lot of time comes with chikungunya as well, depending on the area, because then chikungunya can present with like pronounced joint pain. Typically, the patients are very, very sick, but I think depends, and I don't think of like a delay period. Leptospirosis is also a bacterial syndrome. Sometimes it has a proclivity for muscles. So you develop initially like some muscular pain, and then you can develop a hepatitis, maybe hemolysis, jaundice. It can affect the lungs as well, and you have the classic redness of the eyes. Uh, Strep typhus. I don't know if I have enough knowledge to like say it out loud, but I think of like lymphopenia, thrombocytopenia as well. A lot of like pulmonary syndromes. Brucella is very, very good one. So brucella is you can acquire from drinking unpasteurized milk, and it causes undulating fevers. It can cause a hepatitis, but has a very big proclivity for bone and joints, and loves doing this actually, and can present like weeks later. Can cause sacroiliitis as well. Uh, so that's my bet. Kirtan, what would you add to this?
Perfect, Yusuf. Thank you for running us down the list. And maybe before I say what I think, maybe I want to clarify with Shreya that the final organism was typhus, like strep typhus. Is that correct?
Scrub typhus.
Scrub typhus. Okay, perfect. Thank
Yeah.
you for clarifying that. Yes. So yeah, I mean, if we go down the pathway, like malaria in general doesn't tend to affect joints as much. It can cause arthralgias, but true arthritis is rare. Dengue and chikungunya can cause true arthritis, but from what I remember and from what I know, it's usually more in the small joints, at least initially, like in the fingers, and probably not in the large joints. Leptospira, as Yusuf said, is like people are very sick, like high-grade fevers, hyperbilirubinemia, rhabdomyolysis, thrombocytopenia, none of what we are seeing. And even if that does end up happening, like leptospira affecting joints is a little bit like unusual. Then the scrub typhus part. So now we know typhus belongs to the group of rickettsia, right? So again, like the rickettsia group of organisms tends to present with like fever, petechia, thrombocytopenia, maybe rash, transaminitis, none of which we are seeing. So that would be also unlikely. And then so finally we are left with brucella. Now brucella in general is kind of TB mimic. And brucella and TB both are known to cause sacroiliitis. Our dear friend Eugene presented the case of sacroiliitis bilateral, which I think ended up being the tuberculosis, right? So similarly, brucella is known to mimic like ankylosing spondylitis in the right clinical context. The only probably the reason why it was not high on our radar initially is because, as Yusuf said, right, that you need like undulating fevers, you need like constitutional symptoms, like fevers, night sweats, weight loss. None of what we expected is just 2 weeks of symptoms, but we do know that atypical symptoms can happen. And since it is a fastidious organism, maybe that explains why we didn't culture it in the synovial fluid. And maybe what you need is the Brucella serologist or maybe Brucella PCR from the joint. So, yeah, I mean, Yusuf, the Brucella is what we are going for, right?
That is my vote as well, and I think a lot of the attendees think this is Brucella. I think that's reasonable. You can It can also cause a prostatitis, like a which is culture negative, like you're mentioning, Kirtan, unless you send like a specific test. And really excited to hear from Shreya and to hear if we ever found out if there's like any specific exposure as well, and what happened in this case.
Awesome discussion. I'm loving this. So yeah, so I'm gonna reveal the diagnosis. Malaria was negative, dengue antigen antibody negative, brucella negative, leptospira was negative, scrub typhus came back positive, IgM titer 1 is to 240 and IgG 1 is to 320. So the diagnosis was seronegative reactive monoarthritis of left hip secondary to scrub typhus. So yeah, this is the very extremely rare atypical presentation of scrub typhus. There are hardly like handful number of cases of arthritis in scrub typhus patient. So the reason I wanted to share this case is mainly because of this rare, although the literature mentions that the pathophysiology behind the scrub typhus is vasculitis, and like in any rickettsial disease, it can involve mucosal surfaces, including synovium. But in reality, we have hardly have any cases presented. There is only one still case of still disease secondary to scrub typhus reported till date. And so yeah, and the secondly I wanted to present this because to emphasize the importance of clinical suspicion and patient-based approach, keeping the epidemiology endemic diseases in mind. Otherwise, what are the chances of arthritis patient of scrub typhus presenting with arthritis symptoms? Very less, right? So yeah, that and especially in case like this where treatment is so rewarding. So patient was initially empirically treated with ceftriaxone, and then when the diagnosis came back, so we changed it to doxycycline, and within 5 days, patient was able to ambulate, and he had no further complaints in his follow-up, and IgM and IgG titer also downtrended. So yeah, so when the treatment is so rewarding and it can prevent lethal complications like meningoencephalitis, ARDS, so it's very important to have that clinical suspicion. Yeah, and that's why I wanted to share this case with you all, and I hope you guys had fun with it.
Well, thank you so much, Shreya, for bringing us the case and also the way you presented, right? Like you are telling us that, oh, there are 5 tests, you can pick one of them, and then you kept us waiting all the way. So very elegant way of presentation. So thank you so much. And maybe I can just ask like this clarifying question that like in Nepal is like the vector for scrub typhus like usually found?
Yeah, it's pretty common, especially in the hilly region. So everybody is asking in the comment section want to tell me more about scrub typhus. So it's a rickettsial disease. It's caused by Orangia susugamusi, and like in any other rickettsial disease, we the most common complications, common complaints are fever, fatigue, myalgia, arthralgia. Some patients present with meningoencephalitis. Otherwise, pneumonia is also a common presentation. When the severe complications are like ARDS, septic shock, multi-organ failure as well. Uh, and patient also have transaminitis. So yeah, the patient in this case there is nothing suspicious of scrub typhus, right? When we started exploring the infectious panel, and then we get to know the diagnosis, and especially the treatment and the treatment course and patient's prognosis was so good. And when I was reading about this, I came to know that there are seropositive reactive arthritis, scrub typhus, and seronegative. And seropositive ones have worse prognosis. This patient has seronegative one, so the treatment course might not have been smooth had the patient had been seropositive. So yeah, I wanted to share that as well. So yeah, it was an interesting case, and I wanted to share with our CPS family.
Of course, thank you so much, Shreya, again for highlighting that how scrub typhus can present in unusual ways. And like I will have to do lots of reading today, so I will like figure out that okay, how scrub typhus comes, what are the usual and unusual manifestations. And just the way Shreya presented it, it speaks to how the epidemiology like impacts our decision. Like for example, if you are in a region where like TB is very endemic, you would probably see so many different versions of TB that you would empirically treat so many of them. So like I remember that sometimes back when I was in med school, anyone presents with like slight liver function abnormalities, like let's say ALP GGT is high, immediately they will say that, oh, this is just TB hepatitis. TB can cause infiltration in the liver and can do this. And just they will just treat the TB and things will be fine. Whereas here, if you think about it, like we will do like so much other workup because epidemiology wise we are not very familiar with it, right? So I think it's kind of like similar concept, like that maybe in Nepal, like where the Shria studied, there is like so many cases of scrub typhus that maybe they are well familiar with it, and maybe they know that what are all the unusual ways in which it can present, so it can increase their suspicion. And I'm so glad that their team stick to their suspicion, they got the diagnostic test and they treated it, and patient even did well. So like such a humbling reminder that how diseases can present in unusual ways. So thank you so much, Ria, for bringing us this fascinating case, and I will read a lot about it. Maybe I can ask Yusuf if in his experience he has seen reactive arthritis getting triggered from unusual organisms like this.
No, yeah, thank you so much, Shreya. I think we're used to like the typical presentation of severe disease, but we're not used to the atypical presentation because it's rare, so we don't see it very often. So I'm like Kirtan, excited to learn more. Thank you. I'll throw the mic to Evan for the teaching points.
Super cool case. Thank you guys. Never heard of scrub typhus, so I think this is really interesting to learn from. Kind of going from our teaching points today though. First, we kind of started with the hip pain and the walking. We wanted to isolate if the slope was in the hip. So we're talking about active range of motion versus pain with passive and active range of motion. And if it's only active, then it might not be in the joint. And if it's with passive, then it kind of localizes it more to the joint. And then going kind of a little bit deeper into the whole walking mechanism, you need three things to be able to walk. You need your orthostats, you need the proprioceptive input and the motor output all together to be able to walk. And with this case, it kind of you're able to get it down into the actual joint of the hip itself. And then going all the way back from the beginning, we actually talked about the iliopsoas being the most helpful muscle kind of when bearing weight and to keep this muscle in mind, and with abscesses affecting this muscle. Um, with the young presentation or with the young age of this patient and the presentation, considering that pain is can also be a factor in limiting their range of motion here. And then once we got the haziness that we saw in the X-ray, the differential immediately kind of jumped to ruling out infections early on, so including tenosynovitis, osteomyelitis, and abscesses, just because of the age group, and we want to make sure we don't miss any of these things. However, advanced imaging like MRI is going to be our most useful thing in kind of figuring out what was going on there. Then we talked about septic arthritis and some criteria for that. So with the white blood cell counts, the higher you get, the more likely it is septic arthritis, and just more probable. Crystalline diseases can also occur with the septic arthritis. And then with staph and strep being the most common cause for infection, and we wanted to empirically treat based on probability with Vanc and ceftriaxone. And then we got on to the topic of STIs because of the patient's age and the difficulty culturing here. So like gonorrhea and mycoplasma are harder to culture and don't show up on gram stain. And typically we'd need to change antibiotics since those aren't empirically treated for. And then lastly, we got down to our last kind of treatments here with talking about malaria, dengue, leptospirea, scrub typhus, and brucella, all of these presenting with um, kind of different than how we would expect here. And I think we kind of ended up on brucella just because of we thought this presents most like the arthritis that we were presenting with, but the diagnosis ended up being a kind of an atypical presentation of scrub typhus. I think it was a great case. Thank you, everyone.
Thank you so much, Evan. Thank you, everyone. Hope you all have a wonderful day.